Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving into the complex world of parathyroid disorders in dogs, focusing on primary hyperparathyroidism and renal secondary hyperparathyroidism, as well as some interesting new developments in diagnostic imaging during surgery. These conditions involve the parathyroid glands, which play a crucial role in regulating calcium in the body, primarily through the production of parathyroid hormone. Primary hyperparathyroidism is most commonly caused by abnormal changes, often a benign tumor called an adenoma, affecting one or sometimes multiple parathyroid glands. This leads to a chronic excess of parathyroid hormone secretion, resulting in elevated total and ionized calcium levels in the blood. Surgical removal of the affected parathyroid gland, known as parathyroidectomy, is a common treatment for primary hyperparathyroidism in dogs, similar to its use in humans. However, a significant and common complication following this surgery is the development of low blood calcium, or hypocalcemia. Severe post-treatment hypocalcemia is recognized to occur in approximately 35 to 70% of dogs after parathyroidectomy. This is thought to happen because the remaining, previously suppressed parathyroid glands are slow to resume normal parathyroid hormone production, combined with rapid movement of calcium back into the bone, especially if the bones were previously affected by high parathyroid hormone levels. Hypocalcemia can manifest anywhere from 12 hours to 20 days after surgery, but it is most frequently observed 2 to 6 days post-operation. The clinical signs of low calcium can be quite serious, ranging from nervousness and increased sensitivity to touch, to muscle tremors, heart rhythm abnormalities, seizures, and even potentially death. Identifying which dogs are most likely to develop hypocalcemia after surgery could allow veterinarians to implement more targeted monitoring and earlier treatment interventions, potentially reducing the severity and impact of this complication. This is a key area of investigation in the veterinary field.
That's right, and while primary hyperparathyroidism relates to a problem originating in the parathyroid glands themselves, parathyroid hormone levels can also be affected by other systemic diseases, notably chronic kidney disease. Renal secondary hyperparathyroidism is an unavoidable consequence of chronic kidney disease in dogs. It can begin early in the disease process, sometimes before changes in calcium and phosphorus levels are apparent, or even before the buildup of waste products in the blood, known as azotemia, is detected. This condition involves the parathyroid glands producing excessive parathyroid hormone in response to the changes in mineral metabolism caused by failing kidneys. Managing renal secondary hyperparathyroidism is considered a major goal in the care of human patients with chronic kidney disease, and research is ongoing to find effective and safe ways to manage it in dogs. Beyond parathyroid disorders, accurate localization of the affected parathyroid glands before surgery for primary hyperparathyroidism is crucial for successful treatment. Preoperative imaging is recommended to help identify the abnormal glands. Cervical ultrasound is the most commonly used imaging technique, but its accuracy can be limited by several factors, including minimal enlargement of the gland, difficulty clearly seeing the gland's edges, and the skill of the person performing the ultrasound. Some studies have reported a discrepancy between ultrasound findings and what is found during surgery. This variability highlights the need for improved imaging methods to help surgeons precisely locate the problematic gland or glands before and during the procedure. Newer imaging techniques are being explored to overcome the limitations of traditional ultrasound and scintigraphy, which has shown limited sensitivity for identifying abnormal parathyroid glands in dogs.
Building on the importance of prediction and identification, one study investigated whether presurgical variables could predict post-surgical hypocalcemia in dogs with primary hyperparathyroidism. They looked at a number of factors including age, body weight, and results from clinico-pathologic tests like serum alkaline phosphatase activity, ionized calcium, plasma phosphate, and plasma parathyroid hormone concentrations. Analyzing data from medical records of 103 dogs treated with parathyroidectomy, the study compared variables between dogs that developed hypocalcemia after surgery and those that did not. A significant finding from their analysis was that the median plasma parathyroid hormone concentration measured before surgery was notably higher in the group of dogs that went on to develop hypocalcemia after the operation. Specifically, the median pre-surgery plasma parathyroid hormone concentration for dogs that developed hypocalcemia was 232 picograms per milliliter, with an interquartile range of 108 to 421 picograms per milliliter. This was in stark contrast to the dogs that did not develop hypocalcemia, where the median pre-surgery plasma parathyroid hormone concentration was 81.5 picograms per milliliter, with an interquartile range of 58.5 to 145.0 picograms per milliliter. The statistical difference between these two groups was highly significant, with a p-value of less than 0.001. The study found that plasma parathyroid hormone concentration measured before surgery had a fair to good capability to predict the development of hypocalcemia after the operation. They performed analyses to determine the predictive value and found an area under the curve of 0.78. When using a specific cutoff value of 75 picograms per milliliter or higher for the pre-surgery plasma parathyroid hormone concentration, the test had a sensitivity of 96.6% for predicting post-surgery hypocalcemia, meaning it was very good at identifying most dogs who would develop the complication. However, its specificity was 42.3%, meaning it would also identify a substantial number of dogs who would not develop hypocalcemia as being at risk. While not as strong predictors as pre-surgery parathyroid hormone, the study also noted that dogs who developed hypocalcemia after surgery tended to be older and had lower body weights compared to those that did not. Furthermore, dogs that developed post-surgical hypocalcemia were also more likely to require a longer period of hospitalization following surgery. The median hospitalization time for dogs with hypocalcemia was 6 days, while for those without hypocalcemia, it was 4 days. This difference in hospitalization time was statistically significant. Interestingly, the size of the parathyroid nodule removed during surgery did not appear to be associated with the development of hypocalcemia post-surgery. These results strongly point towards pre-surgical parathyroid hormone levels as a valuable indicator for anticipating this common post-operative issue.
Those are certainly compelling results regarding the predictive value of parathyroid hormone for post-surgical hypocalcemia. Now, shifting gears to managing renal secondary hyperparathyroidism in chronic kidney disease, another study investigated the effects of Paricalcitol, a synthetic vitamin D analog, in 13 dogs with naturally acquired chronic kidney disease. This was a controlled clinical trial using a crossover design, meaning the dogs received both the active treatment, Paricalcitol, and a placebo at different times. The dogs were treated for 12 weeks in each arm of the study. The results showed that Paricalcitol treatment led to a significant decrease in parathyroid hormone concentrations. Specifically, parathyroid hormone levels decreased by 22% with each visit in the Paricalcitol-treated dogs, whereas they increased by 18% with each visit in the placebo-treated dogs. By the end of the 12-week treatment period, parathyroid hormone concentrations were significantly lower compared to baseline in the Paricalcitol group. The study also looked at other markers related to mineral metabolism and chronic kidney disease progression. Fibroblast growth factor 23, another hormone involved in phosphate regulation, significantly increased by 12 weeks compared to baseline in the dogs receiving Paricalcitol. In contrast, there was no significant change in fibroblast growth factor 23 in the placebo group. Regarding proteinuria, measured by the urine protein to creatinine ratio, this marker of kidney damage worsened over the 12 weeks in the placebo-treated dogs, showing a significant increase compared to baseline. However, in the Paricalcitol-treated dogs, the urine protein to creatinine ratio did not significantly change compared to baseline. Ionized calcium levels remained largely unchanged between baseline and 12 weeks in both groups. Despite the average ionized calcium not showing a significant change over time within the Paricalcitol group, the study reported that about half of the dogs, 7 out of 13, developed mild hypercalcemia while on Paricalcitol. This necessitated dose adjustments for some dogs to resolve the elevated calcium. No dogs had to be removed from the study due to hypercalcemia that couldn't be managed with dose reduction. No adverse effects were reported by the owners. These findings suggest Paricalcitol can indeed lower parathyroid hormone in dogs with chronic kidney disease and potentially help stabilize proteinuria, but the risk of hypercalcemia remains a concern. Moving back to primary hyperparathyroidism surgery, another study evaluated the agreement between computed tomography and surgical findings in identifying abnormal parathyroid glands in 20 dogs with suspected primary hyperparathyroidism. They compared what was seen on CT scans with what the surgeon observed during bilateral cervical exploration. The study found very high agreement between CT and surgery regarding the laterality, which side, left or right, and the general position of the abnormal parathyroid glands. However, the agreement for estimating the size of the gland was only fair. Importantly, in 5 cases, pathological parathyroid or thyroid tissue was surgically removed that had not been identified on the computed tomography scan. This indicates that while CT can be helpful for localization, it doesn't always detect all abnormal tissue. In the realm of intraoperative imaging, a separate study explored the use of indocyanine green, a fluorescent agent, combined with near-infrared fluorescence imaging to help visualize normal parathyroid tissue during surgery in 8 purpose-bred dogs. The goal was to see if this technique could aid in identifying parathyroid glands in real time. They administered indocyanine green intravenously at different doses and used a special camera to capture fluorescence. The results showed that indocyanine green, administered at doses between 0.2 and 0.4 milligrams per kilogram, effectively caused normal parathyroid glands to fluoresce. This fluorescence was rapid and persisted throughout the observation period. However, a challenge noted was that the subjective fluorescence levels in the parathyroid glands were similar to those in the adjacent thyroid glands, making it difficult to visually differentiate between the two types of tissue using this method alone. They found that different viewing modalities of the imaging system affected how clearly the fluorescence was perceived. The monochromatic modality showed strong fluorescence of the parathyroid glands, suggesting potential for localization, while objective measurements showed some dose-dependent differences and variations between glands in different modalities. The subjective similarity in fluorescence between parathyroid and thyroid tissue limits the technique's ability to distinguish between them based solely on fluorescence intensity at these doses in normal glands. Despite this, the ability to make the glands visible with fluorescence holds promise for intraoperative identification, particularly for locating ectopic glands that are not in their usual position.
Those results provide some exciting insights and also highlight ongoing challenges. Let's return to the predictive factors for post-surgical hypocalcemia in primary hyperparathyroidism. The finding that a higher pre-surgery plasma parathyroid hormone concentration is associated with developing hypocalcemia post-surgery aligns with some previous research, including studies in human patients. The study specifically proposed that using a pre-surgery plasma parathyroid hormone concentration cutoff of 75 picograms per milliliter could be valuable for clinicians. Dogs presenting with a parathyroid hormone level below this threshold are considered unlikely to develop severe hypocalcemia after parathyroidectomy. This information could potentially inform post-surgical management protocols. For dogs with pre-surgery parathyroid hormone concentrations below 75 picograms per milliliter, less frequent monitoring of plasma ionized calcium post-surgery might be possible, potentially leading to shorter hospitalization times. This could, in turn, reduce the financial burden on owners and minimize stress for the dog associated with prolonged hospitalization. Conversely, dogs with pre-surgery parathyroid hormone levels at or above 75 picograms per milliliter might require more intensive monitoring. While pre-surgery parathyroid hormone was a strong predictor in this study, other variables that have been considered in humans or previous veterinary studies, namely plasma ionized calcium concentration at diagnosis and just before surgery, serum phosphate concentration, and serum alkaline phosphatase activity, did not prove to be valuable predictors in this specific group of dogs. This contrasts with some prior veterinary studies that found a correlation between pre-treatment ionized calcium and post-treatment hypocalcemia. The authors speculated that this discrepancy might be due to factors like fluid therapy administered before surgery, which could normalize or alter ionized calcium levels, making the measurement taken closer to surgery less representative of the underlying severity of the calcium dysregulation. The study also discussed the associations found between age and body weight and the development of post-surgical hypocalcemia. Dogs that developed hypocalcemia were slightly older and had lower median body weights. Age has been previously identified as a variable associated with hypocalcemia after parathyroidectomy. It is hypothesized that older dogs might have had primary hyperparathyroidism for a longer duration, potentially leading to more significant bone changes that predispose them to hypocalcemia after the source of excess parathyroid hormone is removed and calcium rapidly moves back into bone. Additionally, older dogs may have other health issues, like chronic kidney disease, which could further complicate calcium balance. However, adding age and/or weight to the statistical model alongside pre-surgery parathyroid hormone concentration did not improve the model's ability to predict hypocalcemia in this study. The lack of association between nodule size and post-surgical hypocalcemia observed in this study is consistent with some other findings, although some human studies have reported a relationship between adenoma size and hypocalcemia. The study also looked at whether calcitriol administration close to the time of surgery affected the development of hypocalcemia. Due to the very small number of dogs who received calcitriol within 24 hours of surgery and met the study's inclusion criteria, no definitive conclusions could be drawn about its effectiveness for preventing post-operative hypocalcemia. Based on their finding that dogs with a preoperative parathyroid hormone level below 75 picograms per milliliter are unlikely to develop hypocalcemia, the authors suggest that preoperative calcitriol supplementation may not be necessary in such dogs.
Expanding on the management of renal secondary hyperparathyroidism, the study on Paricalcitol highlighted its effectiveness in reducing parathyroid hormone levels, which is a significant goal in managing this condition. The observed decrease in parathyroid hormone with Paricalcitol treatment supports its potential use in attenuating renal secondary hyperparathyroidism in dogs. The study authors discussed how controlling renal secondary hyperparathyroidism is a major objective in managing chronic kidney disease in humans, and previous data in both humans and dogs suggests that treatment with vitamin D compounds might offer survival benefits. These benefits are thought to stem not only from better control of parathyroid hormone, but also from potential protective effects on the kidneys themselves, such as reducing inflammation, scarring, and proteinuria. While the study didn't evaluate long-term survival, the finding that proteinuria, a marker of kidney damage progression, remained stable in the Paricalcitol group while worsening in the placebo group could be interpreted as a potential positive effect, although this change was considered modest. However, the study also underscored important potential downsides to Paricalcitol treatment. Despite newer generation vitamin D analogs like Paricalcitol being initially hoped to have fewer side effects, particularly hypercalcemia, than older forms like calcitriol, this study found that mild hypercalcemia did develop in approximately half of the treated dogs. This necessitated dose reductions, indicating that close monitoring of ionized calcium levels is still essential when using Paricalcitol. The results regarding hypercalcemia are consistent with recent findings in human medicine where Paricalcitol treatment increased the risk of hypercalcemia compared to placebo. The study also noted an increase in phosphate concentrations and the calcium phosphate product during Paricalcitol treatment. While hyperphosphatemia is a known risk factor for chronic kidney disease progression in dogs, the increase observed in this study was mild and did not lead to overt hyperphosphatemia in any dogs. Nonetheless, it emphasizes the critical importance of ensuring phosphate levels are well managed before initiating Paricalcitol. Furthermore, the study found a significant increase in fibroblast growth factor 23 with Paricalcitol. This is consistent with observations in both dogs and humans treated with vitamin D compounds. The implications of chronically elevated fibroblast growth factor 23 in dogs are not fully understood, although it has been reported as a risk factor for mortality in dogs with chronic kidney disease. Therefore, the decision to use Paricalcitol needs careful consideration on a case-by-case basis, weighing the potential benefits of reducing parathyroid hormone against the risks of hypercalcemia, increased phosphate, calcium phosphate product, and fibroblast growth factor 23, and recognizing the need for intensive monitoring. Regarding surgical planning for primary hyperparathyroidism, while computed tomography showed good agreement with surgery for locating abnormal parathyroid glands by side and position, the fact that some pathological tissue was missed on the scan reinforces the importance of traditional surgical exploration. Bilateral cervical exploration, where the surgeon visually examines both sides of the neck, remains an essential part of accurately diagnosing and treating primary hyperparathyroidism. The study on indocyanine green near-infrared fluorescence imaging suggests a potential tool for assisting surgeons during the procedure. The ability of indocyanine green to cause normal parathyroid tissue to fluoresce makes it a promising technique for helping locate these glands, especially those that might be small or in unusual locations. However, the challenge of differentiating parathyroid tissue from thyroid tissue using this method based solely on fluorescence intensity at the tested doses and modalities indicates that further research is needed. Future studies in dogs with actual parathyroid pathology are necessary to determine if this technique can help distinguish between normal and abnormal parathyroid tissue, or between parathyroid and thyroid tissue in disease states, and to refine the optimal dose and imaging parameters for clinical application.
So, it seems predicting and preventing post-surgical hypocalcemia after parathyroidectomy for primary hyperparathyroidism is significantly aided by assessing preoperative plasma parathyroid hormone levels. The research supports the idea that a level below 75 picograms per milliliter indicates a low risk of severe hypocalcemia. This key finding from one study has practical implications for tailoring post-operative care, potentially reducing monitoring intensity, hospitalization time, and costs for low-risk patients. The challenges in imaging discussed, whether it's the limitations of ultrasound, the fair agreement of computed tomography for size, and missing some pathology, or the current difficulty with indocyanine green fluorescence differentiating parathyroid from thyroid tissue, all underscore the fundamental need to reliably identify and remove the affected parathyroid tissue in primary hyperparathyroidism. Successfully treating this condition hinges on finding and removing the source of the excess parathyroid hormone. While imaging techniques like computed tomography and new methods like Indocyanine green fluorescence show promise for aiding localization, they are not perfect substitutes for thorough surgical exploration and pathological confirmation. The retrospective nature of the study on predicting hypocalcemia introduced some limitations, including potential for incomplete records. Variability in laboratory methodologies for tests like parathyroid hormone and alkaline phosphatase, and the limited duration of post-surgical monitoring for hypocalcemia in some cases. Different assays used to measure parathyroid hormone, although believed to be comparable in this specific study's context, can be a factor in result interpretation. Despite these limitations, the strong association between high pre-surgical parathyroid hormone and post-surgical hypocalcemia, along with the high sensitivity of the 75 picograms per milliliter cutoff, provides a valuable tool for risk assessment.
And while surgical intervention is the primary treatment for primary hyperparathyroidism, managing the parathyroid gland's response in chronic kidney disease involves different therapeutic strategies, such as the use of vitamin D analogs like Paricalcitol. As we discussed, the study showed Paricalcitol effectively reduces parathyroid hormone levels in dogs with chronic kidney disease. This is important because renal secondary hyperparathyroidism can have serious consequences beyond just elevated parathyroid hormone, contributing to bone disease and potentially affecting other body systems. However, the potential adverse effects observed with Paricalcitol, such as hypercalcemia and increases in phosphate and fibroblast growth factor 23, mean that its use requires careful consideration and close monitoring. Clinicians must weigh the potential benefits for controlling parathyroid hormone and possibly stabilizing proteinuria against these risks. The study authors suggest that starting with a lower dose of Paricalcitol might help mitigate the risk of hypercalcemia, drawing on findings from human medicine. The findings regarding increased fibroblast growth factor 23 with Paricalcitol are consistent with other studies, and while the long-term impact of elevated fibroblast growth factor 23 in dogs is still being investigated, it adds another layer of complexity to the decision-making process. Ultimately, the decision to use Paricalcitol for renal secondary hyperparathyroidism in dogs should be individualized, based on a thorough assessment of the patient's condition and willingness to commit to diligent monitoring. These studies collectively highlight the ongoing efforts in veterinary medicine to better understand, diagnose, and treat parathyroid disorders, whether they are the primary problem or secondary to other diseases like chronic kidney disease. From predicting surgical complications and improving gland localization during surgery to finding effective ways to manage hormonal imbalances associated with chronic disease, research continues to refine best practices for these conditions.
Thank you for listening to the Veterinary Medicine Digest. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging. If you're enjoying this, remember to like, share, and subscribe, as proceeds from this channel go directly to providing vital veterinary care for animals in need. Even a small amount can transform an animal's life and ease an owner's burden.